The ADC Part 1 pass rate is between 15 and 20%, 1 in 5 roughly. That number has been consistent for years. It is not getting better. The candidates who fail this exam are not unqualified. Most of them have years of clinical experience. Many have postgraduate training, or most of them studied for months before sitting. So I want you to understand from the very first minute of this trial course that the exam is not selecting for intelligence or dedication. It is selecting for something more specific than that. It is selecting for whether you understand what exam is actually testing. Most candidates find out only when they fail. Every answer in the ADC Part 1 is evaluated against single standard. You will not find this stated prominently in most preparation materials, but it is in the official ADC documentation, and it controls every correct answer in the exam. Minimally competent recent Australian dental graduate. This is the benchmark. Not internationally best practice, not what you learned in your home country, not what you experienced through. The minimally competent recent Australian dental graduate. What does it mean? It means the threshold level of safe, appropriate clinical practice expected of someone who had just completed their dental degree in Australia, practicing in Australia following Australian law and Australian guidelines. That is the standard you are being measured against. Let me give you a quick example. A question involves a patient who needs a panoramic radiograph, an OPG. You have ordered them before. Your instinct says it's clinically reasonable. You selected that option. It is wrong. Not because OPGs are bad clinical practice, but because the Australian Radiation Protection Standard, 𝗓𝗏, requires individual justification for every radiograph. If the vignette does not give you a specific clinical region that justifies a full OPG, the more targeted investigation is the correct answer. Your clinical habit, which may be entirely reasonable in your home country, does not match the Australian benchmark. That distinction between what is clinically reasonable and what matches the Australian standard is the exam, in every vignette, in every question. Now, I want to tell you something that most candidates do not find out until they have already failed the exam. The ADC Part 1 does not give you one overall mark. It measures your performance across 4 clinical clusters. Each cluster is domain of competency: clinical knowledge, patient management, health promotion, professionalism, and ethics. To pass the exam, you must pass every cluster. Failing one cluster means failing the exam. It does not matter if you perform well in the other 3. One failed cluster, one failed exam. The candidates who come back for a second sitting and most who fail come back, often failed on a single cluster. C1 clinical knowledge, because they applied international guidelines instead of Australian ones. Or C4 professionalism, because they did not know the open disclosure sequence required by AHPRA. Here is something you can use immediately. Question 5 in every ADC vignette tests the autonomy and professionalism cluster every single time. The topic of the vignette is irrelevant. A case about pediatric dentistry, a case about restorative management. Question 5 will ask about patient and autonomy and open disclosure, or your ethical obligation when things go wrong. Once you know that, you can prepare for question 5 as a category, not just as random ethical question or ethics question. I said earlier that exam does not select for dedication. It does select for one specific skill: reasoning from a clinical vignette, using the Australian standard under time pressure against options that are deliberately designed to look correct. Every wrong answer option in the ADC is a distractor. But distractors in this exam are not random wrong answers. They represent real clinical choices that real clinician makes. Choices that are clinically defensible, but that do not match the Australian benchmark, or that represent a known cognitive error, or that are based on an outdated guideline. Every wrong option represents a trap. Every trap has a name. When you select an answer and you feel confident, ask yourself, am I confident because this matches the Australian standard, or Am I confident because this is what I would do in my own practice? Those two things are not the same. And the exam is testing the first one, not the second. That shift in how you read a question from what feels clinically right to what matches the Australian benchmark is the entire skill this course trains. Everything else known from it. You are about to read the final section of session 1. It covers the 3 Australian regulatory frameworks that appear most frequently in exam questions: the therapeutic guidelines, 𝗟𝗏 and AHPRA open disclosure. Read it carefully, not to memorize it, to understand why it exists and how it shows up in a question. Then in session 2, we are going to work through the Alexander case together, the only official ADC sample vignette. After session 2, you will sit the trial exam comprising of 20 questions to be completed in 30 minutes. When you submit the test, you will receive the result. Dashboard will be showing you performance broken down by cluster, by difficulty, and by trap category. That profile is honest. It will show you exactly where you stand before you have spent a single dollar on preparation. You know the benchmark, you know the cluster structure, you know that this exam tests reasoning, not recall. That is a meaningful advantage. Use it.